the title of my talk is Should Mist Be First Line for BPH? And just by show of hands, how many of you perform a mist like Urolift? How many perform Urolift? And how many perform Resume? Okay. Does anyone do iTind or Optilume? Any of those? Okay. So some people with Optilume. So we'll touch on that a little bit. And this is meant to be more of a thought-provoking talk to get you just kind of thinking about this concept and go from there. So this is one of my favorite slides. It's very old. It's from 1984, but I think it captures the disease state very nicely and essentially highlights that BPH is prevalent. By the time you're 80% of men will have it histologically, even by age 50. Many of us in this room are probably getting up at least once or twice at night last night. And so it's very prevalent, and there's a huge need. It's over $1 billion in the healthcare industry in the United States. We know that BPH medication, especially combination therapy, is effective. Multiple large studies have been performed. We know medical therapy is superior to watchful waiting. Combination therapy is superior to individual meds. As you can see, in this graph, the combination therapy has a reduction in progression of symptoms, a reduction in the need for surgery, reduction in progression to develop retention, and certainly an improvement in IPSS, an improvement in urinary flow. The combination therapy is more effective than either medication alone. However, BPH medication is not without long-term risk. There's growing data, which we'll review today, that suggests alpha blockers may be associated with cardiac and cognitive complications, 5-ARIs with psychological complications, and then obviously these medications have an impact on sexual function. We also know compliance is poor, so up to 60 to 80% of patients will stop taking BPH medications within a year. Up to a quarter of them will progress and have worsening symptoms. And of those, up to 1 to 2% will still develop acute retention. And also we know that if you wait and delay surgery until failure of medical therapy, they don't do as well versus upfront surgery. So alpha blockers, one of the mainstays of our treatment, very effective in the right patients. So 30% of patients, you put them on an alpha blocker, they may not have symptom improvement. And then significantly, ejaculatory dysfunction affects a significant number of men. 5-alpha reductase inhibitors also has a slew of side effects, including erectile dysfunction, decreased libido, ejaculatory dysfunction, and a lot of these are variable. This is just some of the many studies that have looked at this topic, but essentially in large groups of patients, post-finasteride syndrome is probably the most common. That when patients come in to see me, they're always asking about this one, where you can have prolonged erectile dysfunction for up to 4 years or longer after stopping the medication. And we know from the MTOPS and other trials that finasteride or a combination can cause worsening ejaculatory function, worsening sexual function, hypoactive sexual desire, and rarely gynecomastia. So certainly when patients come to see me in the office, a lot of them have already either tried a medication with their primary care and not been counseled, or they come in because they've read these effects and they don't want to be on a medication. There's some new data that's recent that suggests other associations. So tamsulosin, in this large study of over 175,000 men, the primary outcome they were looking at was a new diagnosis of cardiac failure based on exposure to either a selective or a non-selective alpha blocker or a combination therapy. And they found that alpha blockers alone were associated with a new diagnosis of cardiac failure. And combination therapy also had it, but alpha blockers in particular had the highest risk. Now you might say, well, this is a large cohort, so they did a multivariate analysis controlling for cardiogenic and cardiovascular risk factors, and they still found the same association, that alpha blockers had an increased risk of new cardiac failure. Non-selective alpha blockers were at higher risk than a selective alpha blocker, and also the duration of exposure. So if you were on it more than 420 days, you had a significantly increased risk. So even in men, you may put on an alpha blocker if they're in their 50s. I think it's worth considering if you're going to potentially put them on this for 30 to 40 years, they may be at risk for some of these other long-term effects and some that we don't know about yet. This study has found an association between tamsulosin and dementia. So interestingly, the alpha-1A receptor is not only present in the urologic system, but it's also present in the brain. And in mice, if you block that receptor, they actually become poor cognitive learners. And if you put them in a maze, they forget, they're really bad at learning. And if you stimulate that receptor, they actually become very smart. And so the same is true in humans. We have decreased expression of this receptor in patients who have dementia. And so this study sort of sought to look further at that by looking at the use of tamsulosin, linking it to Medicare claims for dementia. And essentially they found that long-term tamsulosin use did have an increased risk of a new diagnosis of dementia compared to other BPH meds. And you can see it was 31.3 versus 26 cases per 1,000 person years. So admittedly, it's not the most striking difference in terms of person years. However, if you think of this on a global scale of patients with BPH, that difference becomes more striking in terms of absolute numbers. Moving on with 5-alpha reductase inhibitors, in addition to all the sexual side effects, there's good data to show they may be linked to depression. So these are several studies that have looked at large cohorts, and they found increased risks for new diagnosis of depression that was sustained. So even in this last study of over almost 100,000 men in Canada, the first 18 months had the highest likelihood of having a new diagnosis for depression, but then even after that, if you stay on the medication, they were still more likely to have a diagnosis of depression than a matched cohort. So with all that background, when I see a 55 or 60-year-old man in the office and we're talking through the BPH guidelines, I keep these things in the back of my mind, and I do have an informed discussion with the patient about some of these risks, because I think if you're looking at 20 to 30 years on a medication, you have to inform the patient that we may not know everything, but there's these potential associative risks. And in contrast, I would say MIST procedures have really come onto the field to offer an alternative to meds with, the concept behind a MIST as a minimally invasive surgical therapy is it's easy to perform. Patients recover really quickly. It can be done either in the office or in an ambulatory surgery center at reduced cost, minimal recovery, and then minimal impact on sexual function. And the two main players historically in the last few years have been the prostatic urethral lift and the water vapor thermal therapy, or the Resume. There's these two new players, the iTind, which is an implantable temporary device that causes ischemic necrosis in the prostatic fossa, and also the Optilume, which is a paclitaxel-coated balloon that creates an anterior commissurotomy, for which there's growing data, 1 to 2 years worth of data that is very promising. But in general, MIST procedures are durable for at least 3 to 5 years. The data is growing. You can see here, if you look at all the metrics that we look at for BPH, like IPSS improvement, quality of life, Qmax, TURP and aquablation are there on the left, but then Resume and Urolift. And even though they're slightly decreased in terms of improvement, there is still improvement, and this is durable out to 3 or 4 or more years. And also no impact on sexual function in terms of ejaculatory disorders or bother. This is some early data for the iTind and the Optilume as well, out to 2 or 3 years, that shows a similar improvement that's durable in terms of IPSS improvement and Qmax. So if we compare patients who undergo a Resume or a Urolift to patients who, from the MTOPS trial, who are on medical therapy, and say, how do they compare? We can see that patients who had a resume treatment, which is shown there on the blue line, really, if you compare it to a single medication like doxazosin or finasteride, they actually did better on resume. And if you compare it to the combination therapy, then it was pretty comparable in terms of IPSS improvement and Qmax as well. So I would argue, keep in the back of your mind for those patients where you're just putting them on one medical therapy and not a dual therapy, perhaps even the resume would be superior to that. And then what about sexual function? So the main, one of the compelling arguments to be wary of medications is the impact on sexual function. And so here you can see that in this case, the resume has no impact on worsening sexual function. Sexual function remains the same, whereas long-term daily medication over time, we see a decline in overall erectile function and overall satisfaction. And you can see here the resume is the blue line, and the combination therapy is the purplish line, and then the MTOPS control patients are also down there. And then a similar analysis looking at Urolift found the same in terms of sexual function, that Urolift did not have any worsening of sexual function compared to patients on medication who did show a decline in function. Interestingly, here the Urolift cohort for the first 2 years actually had an improvement in reported erectile function and sexual satisfaction. But I think the more important point is that it's not getting worse. So what about cost? Another argument I've heard as well, if we're going to go do a procedure maybe in the ASC or in the office, this is potentially a lot more of an expensive option. How does this play out? This paper looked at just a cost analysis by Medicare cost models, and they essentially just looked at what is the cost of alpha blocker and 5-ARM medications per year. And then they found the costs for Urolift and resume. And you can see here that in the office, water vapor therapy costs about $1,700, which is very slightly more than a year's worth of medication. And so if you look at the equivalence time, essentially that means is that after about 1.05 years of being on a medication, it's covered the cost of the water vapor thermal therapy. So as long as you're getting a benefit beyond a year, you actually save money by doing an upfront surgical procedure. And for Urolift, the number is 1.64. So again, if your patient if you save them a year and a half of medication, you've made up for the cost. This is an interesting study where they did a cost effectiveness analysis. So they, using the literature for these BPH procedures, they generated a list of the adverse events after surgeries: incontinence, ED, retreatment, stricture, UTI. And they were able to generate adverse events ratios for each procedure as well as expected outcomes. And then they essentially modeled patients to undergo a therapy, and then they modeled the possible adverse events after each of those therapies and statistically what would happen. And they looked for over 2 years. So essentially, let's say you get a Urolift, there's a 12 to 14% chance of having a retreatment within X amount of time. They model that in. There's X percentage of needing to go back on medication. And so in the cost analysis, you can see on the horizontal axis is the average IPSS score, and then the vertical is the cost. And so the combo medication therapy over here in red it's the least effective in terms of IPSS improvement. It's the most variable in cost because whether you're using generic versus brand name can affect the cost. On the other end of the spectrum, a TERP or a green light is more expensive. It has the most IPSS improvement, but because of the increased cost, it's higher. And so this study suggests that mists warrant consideration as first line, and in this case particularly the resume, because of its position with a moderate improvement in IPSS and a relatively low cost. Now that study was only looking at a 2-year time frame. This study did a similar modeling effect, only it went out to 20 years. So they looked at either pharmacotherapy versus Resume versus Urolift up front. They modeled 3 potential outcomes, and then they looked over 20 years. So down here you can see the different strategies. Some patients were modeled as having upfront Resume, some were having drug therapy, and some were having Urolift. And then statistically, if the patients on pharmacotherapy progressed, then they either were then received, in this case, the Resume, or in this case, they received the Urolift. And then every 3 months, they iteratively modeled out the adverse event rate. And if they needed a third procedure, they would then get a TURP or go back on medication. So the advantage of this model is it looks over a longitudinal period of 20 years. And you can see over here on this figure that the IPSS improvement, if you had upfront surgery, occurred very quickly. Whereas if you were started on pharmacotherapy, it took longer to see the same IPSS improvement, because over time the medicine is less effective, and then over time you may end up needing to go on getting a surgical procedure if you didn't improve on the medicine. So overall, the conclusion was that initial upfront water vapor thermal therapy is the most cost-effective for patients with BPH. You can see the overall cost was about $15,000 over a 20-year period, and it had a high quality adjusted life years. And if you compare that to upfront pharmacotherapy and then getting a Resume later, it's $15,000 cheaper if you do the procedure up front. And that's likely because over 20 years, the cost of medical therapy adds up, whereas upfront Resume therapy obviates the need for medicine for a significant period of time, and in some patients never have to be on medicine at all. So if you model it over a longer period of time, it's significant savings to consider upfront procedures. And then the last point I would make is there is a mist for everyone. So in my practice, you know, if there's many patients, you could be young, you could be elderly, you could have multiple comorbidities and not be a candidate for a surgery with general anesthesia. You don't want medications. You're interested in preserving sexual function. I joke, but I've had a patient who is 55 came in and he's like, I think all 55-year-olds should just get this as prophylaxis so that they don't have symptoms in the future. So no, that's an interesting idea. I don't think we're there yet at recommending prophylactic mist therapy, but I think the point is, and then depending on prostate size and shape, you can customize the procedure that they need based on things like if they have a median lobe. So in summary, medications are not without side effects. There are certainly effects on sexual function and potentially other impact long-term on cardiac, cognitive, and psychological. And then also patient compliance is an issue. Mists are lower risk than surgery. They're durable for at least 3 to 5 years. They do preserve sexual function, and they show similar or even greater improvement in symptoms than long-term medication. And certainly in the case for Resume, there's favorable cost profiles. And I think it is important to note that one size does not fit all. So when we talk about mist therapy, we have to remember that it's still based on a personalized approach. Thank you very much.